Hello viewers, today we have with us two very renowned surgeons, Dr. Ragavan, specialist neurosurgeon, Apollo Hospital, Chennai, and owner of CSK Clinic, and Dr. Meera Ragavan, who is also a specialist robotic surgeon, Uro-Oncologist. So today we will be discussing on the robotic program itself. Hi doctor, how are you?
Nice to meet you, Nandi.
Hi, how are you? I would like to get answer to these questions, which are very important for my own demographic. I hail from Bangladesh, so people are very much interested uh, to know about the advancement in the field of surgery, such as robotic surgery, and what are the things that differentiate between traditional surgery and robotic form of surgery. Please, sir.
Hi, viewers. Nice to meet all of you. It's a pleasure to be in conversation with you. The surgery, the principle of a surgery is to perform an operation in order to make things better for the patient. So, when in the process of making things better for the patient is obviously subjected to some difficulties as well, such as pain, recovery, and other factors before they become better. So, surgery is done inevitably on patients who have a condition, a problem, a tumor, a cancer, whatever it is. So, the traditional surgery involves making big cuts, big holes to do the operation, removing lots of tissue, and in the process of removing tissue, some surrounding tissue damage will happen as well, in turn, which will have an impact in the overall recovery process. So, generally, traditional abdominal surgery, you are talking about big scars and recovery over a long period of time. With the advent of laparoscopic surgery, many of these things got better. That is, the scar aspects, the pain aspect came down. However, laparoscopic surgery also has its limitation because you are doing a 3D operation using a 2D vision. In addition to that, laparoscopic instruments are very straight instruments, almost like eating like a chopstick instead of using your hand to eat. So you are trying to do a complex thing by using two straight sticks in a 2D vision. So as a surgeon, it poses challenges, and in that process, the accuracy of surgery always can be achieved only after high amount of training with laparoscopic surgery. Then the robotic surgery came. Robotic surgery is using a robotic platform where we are trying to do a surgery, maintaining the principles of the surgery, maintaining the principles of laparoscopy, however, overcoming the downsides of laparoscopy. That is robotic surgery.
Thank you, sir. And ma'am, would you like to enlighten us on your field of operation, or your line of action in this
The
regard?
same advantages which robotic surgery has over the conventional process of the laparoscopic surgery yields itself very well to the field of gynecology and urogynecology very well. For example, in urogynecology, we have a condition called vault prolapse, where women suffer from complete eversion of the vagina following a previous hysterectomy due to the lack of the support. Now, this entails the woman to have a major surgery whereby we lift up the vault and anchor it to the sitter bone or the sacrum. So most of these women are elderly, they have comorbid conditions, they are obese, they've had previous surgeries and thereby lesions inside the tummy are expected. And it's a very deep surgery within the pelvis where the reach of the laparoscopic instruments can be compromised because these are straight instruments, or the magnification can be compromised because it's a 2D vision where you're not appreciating the depth very well. So a robotic surgery, because of the dexterity of the movements of the arms of the robot, or the magnification with which we can see the organs in the depth of the pelvis, or the zoom effect and the 3D effect which is offered, helps us to do a very good reconstructive job of anchoring the vault to the mesh and thereby the mesh to the sacrum without the risk of injury to the nearby organs, which could potentially happen with the conventional surgery. And this yields itself very well because these are elderly patients, as I said, with comorbid conditions, and the patient can be discharged within 24 hours as a day case procedure.
Okay.
And all that the woman is left with is keyhole on her tummy rather than a big midline scar.
Okay.
And the post-operative stay is reduced, thereby the complications in the elderly due to chest infection or difficulty in breathing or clots and veins in lungs is minimized. Patient has lesser pain, and a better cosmetic appeal, thereby multiplying their recovery pathway because of the morale upliftment which happens with these effects. So definitely robotic surgery has a place to stay as far as the field of urogynecology or gynecology is concerned.
Will you please tell us on the procedures that you are undertaking in this particular pelvic floor disorders or your field of specialty?
Yeah.
What are the procedures you're carrying
See,
out?
both the gynecology and urogynecology, we can do a hysterectomy with multiple fibroids, for example, or myomectomy, whereby we remove the fibroids with the um, conservation of the uterus, or do cancer surgeries for early cancers, especially of the uterus or the cervix, with the robot. Reconstructive procedures whereby a young woman with a prolapse of the uterus wishing to have childbearing in the future, we anchor the uterus to the sitter bone or the sacrum with a mesh, typically, and that can be done as a day case with the robotic surgery. Similarly, I've mentioned about prolapse-related correction or reconstruction can be undertaken. Fistula repair, especially in the bladder, post-surgery or post-delivery, can also be repaired with the robot. Reconstruction of the ureter after an injury can also be done with the robot. So, multiple gynecological procedures, especially in the context of a large uterus, multiple fibroids, coexisting comorbid conditions, obese patients, multiple laparotomies in the past where we expect scars or adhesions, lends itself very well to the robotic surgery without increasing the morbidity which would otherwise happen with an open surgery. So that is the advantage of the robotic platform.
So we can expect organ conservation in that way.
Definitely,
Mostly.
if it is an appropriate indication.
And sir, in your field of specialty, what are the procedures you can undertake with robotic arm or robotic program?
Robotics became very popular in the field of urology, especially in the field of Uro-Oncology. The majority of the procedures done with the robot across the world is prostate cancer surgery called radical prostatectomy, where the whole prostate is removed. In addition, from that point onwards, robotic surgery expanded itself to almost every aspect of urology. So all cancer surgeries, almost all of them are now done with a robot, removing kidney, that is total radical nephrectomy, part of the kidney, that is partial nephrectomy. In that situation, removing part of the kidney and preserving the rest of the kidney is done exceptionally well with the robot, with just a minimal scar. Removing prostate, radical prostatectomy, removing bladder, that is radical cystectomy, and nowadays we can even reconstruct the whole thing with the robot without making any big scars at all. Then if you go into non-cancer branches, pelvic-ureteric junction obstruction, that is the way you were born, where the kidney pipe is blocked up, and you can re-stitch the whole thing using a robot so that the kidney is not blocked anymore. So we call it PUJ obstruction, and that is treated well with the robot. Ureteric re-implants are done with the robot. And anything which is complex, where laparoscopy is going to struggle and open surgery is required, robotic will come there. So robotics in urology is big, especially in uro-oncology, is almost the standard of care now.
And so how good an option it would be for an older population, because in my place we have an issue with older population because they come with complexities, spectrum of complexities. So how good is an option, the robotic program for the elderly and the pediatric as well?
Robotics plays exceptionally well for these two populations, and the reason is very simple. In pediatrics, the physiology of the patient is very small and very early, whereas in elderly population they have exhausted physiology, so they have a lot of comorbidities, other problems. So in those patients, trying to make a big scar and do an operation and give them a long recovery is difficult for them to come out of that operation, whereas robotic surgery yields itself nicely for that. They get the same quality operation with just 5 holes, and therefore they get up, sit, and get discharged the next day, if not the same day. So even the elderly population, pediatric population, will benefit immensely with the advent of the robot, which otherwise they were struggling when in the open surgery era.
Okay. And please do explain to us the cost aspect or cost benefit or comparison. What do you suggest? What do you think it is better an option to undertake robotic program rather than taking conventional program?
If you take, if you compare direct, well, so like any other program, we have to compare direct cost and indirect cost.
Exactly.
So direct cost for any operation for a robotic platform, from open to laparoscopy to robot, there'll be about 10-15% change for each section. As far as the direct cost is concerned, that is patient coming paying money for that services that they get. However, when you take the indirect cost into consideration, imagine a young 40-year-old with a tumor in the kidney. He has to take off from work for 3 months. The institution is losing, he is losing his pay, he is away from work, his productivity is low when he goes through a conventional surgery. Imagine that gentleman going through a robotic surgery. He'll be away from work for about 1 week, 10 days the best, and he's back to work. Where are we going to put the productivity there? We have to factor that in as well. So when it comes to the overall productivity of the human being, robotic surgery scores equal, if not better than open surgery. You can do the same thing for each condition that we deal. When you take both the indirect and direct cost together, we will find very simply that the robotic platform and robotic platform based surgeries is equivalent to the open, if not better than the open.
Okay, sir. And it goes the same for pediatric population as well?
Same as the go for across all age group. Imagine an old gentleman having to go through a big abdominal surgery, stays in ICU for 4 days, stays in the hospital for 10 days, have a long recovery, and in Southeast Asia, in India, Pakistan, Bangladesh, we are the one who look after the family, and therefore we have to take off to look after them as well. But on the other hand, if the same gentleman recovers within 2 days and back to look after himself, see the productivity that is increased.
Fast recovery, less wound, and zero infection we can expect from the program.
Zero will be a high order, but very, very high chance of no infection.
It's a figure of speech. And ma'am, like in our female demography, we have the prevalence of anemic condition. How it is an option for the patients, for the youth who are anemic in a way. That is prevalent.
Because the blood loss is very low as far as the robotic surgery is concerned, we can take up these anemic patients with an iron infusion and lessen the blood loss. In fact, they will lend themselves as better candidates for robotic surgery because the risk of blood loss is much lesser compared to a traditional conventional open surgery. So there are basically not many contraindications to using the robotic platform as far as surgical procedures are concerned. People with restrictive lung disorders, where they have a restrictive lung capacity, probably are the only ones where we cannot use the robot because the buildup of pressure in the tummy will further restrict the lung capacity. So, apart from that, we do not envisage any particular contraindication for robotic platform in the usage of surgical field.
So, both of your specialties do have two common things which we would like to have answer. That is on UTI and the renal stone or bladder stone, whatever. Please enlighten us on that.
Kidney stones happen in both genders. It doesn't discriminate the gender. So it is a common problem, especially in the age group between 20 and 40, in the productive age group. The most important component of this kidney stone, as why it happens, is because of poor water intake. So anybody who presents with severe pain in the tummy, going down into the private parts, rolling in pain, vomiting sensation, probably has a stone. Sometimes we do get stones diagnosed incidentally when you do a scan as well. The biggest problem with the kidney stone is that the patients suffer a lot. They have lots of pain, and in women they even describe it's slightly worse than labor. Once diagnosed with stones, not every stone needs an operative intervention. So if you have small stones, which happens in the majority, by drinking adequate water and some tablets, you flush the stone out. But in patients who have a larger stone, usually stones above 8 mm, they sadly will end up with a surgery in order to clear the stone. Sad because they have to go through a procedure, but the happy thing is that the stone will get cleared. The success rate of stone clearance operations are extremely high. We are talking about near 98-99% success. either in the first sitting or 1 or 2 sittings, the stones will get cleared. So renal stones is a common problem in both genders, especially in active productive age group, because of inadequate water intake. It's easily treatable, and they sadly suffer with pain, but we can make things better for them.
What is the size of the stone that will require surgeries? Because we have two different notions. Like not every stone requires operative intervention. But what do you suggest? When the stone, how big is the stone, and what is the intervention?
There are two things we need to look at: stone size and stone location.
Okay.
If you have a stone size 5 mm in the kidney, it's not going to trouble you. You don't need an operation, you don't treatment at all. This is a stone size of 5 mm in the tube from the kidney to the bladder, called ureter, will cause you lots of pain, and therefore you will need treatment, which inevitably is based on medical therapy, but failed medical therapy will inevitably lead to surgery. And surgery also is done with a camera and endoscope, and therefore there is no cut stitch. Patient can get admitted in the morning and go in the evening. And now one of my patients even went for a cinema in the same night. So renal stone surgery has become much better with time. Gone are those days when large cuts were made to remove stones. We are now able to do those majority of the time using in a day case setting, using good technology, and give the patients a good stone clearance.
So you are saying that simplest of procedure done in an advanced facility gives a definite advantage to the patient. Like one of the
With a
patient went for
very
movie.
good and a quick recovery as well.
Fine. That's what patient requires.
Yes.
And ma'am, from on your side.
More than stone treatment, we have to educate people about stone prevention. Because once a stone formed, as we know that they are at risk of developing stones again in their lifetime near to the order of about 50 to 60%. So if somebody develops a stone very young in their lifetime, they are going to have 3-4 episodes in their lifetime because they are at higher risk. So what puts them at a higher risk is something we need to act upon. So water drinking habit is something which has to be strongly encouraged. At least 3.5 liters water per day will flush out the solutes, and thereby they do not have the capacity to form stones. Reduction in the non-vegetarian diet intake or excess protein intake in the form of meat has to be encouraged. And they have to look upon certain blood chemicals in their body which can predispose them to developing stones. Say, for example, uric acid, calcium levels, parathyroid hormone levels, as well as their vitamin D levels. If there are vitamin D deficiency, they seem to have a higher preponderance of stone formation, and they have to be treated adequately so they don't form stones in the future. Having excess citrus fruits, acidic agents, or certain types of vegetables which have oxalates in them, like greens, spinach and cabbage and cauliflower, predisposes them to develop stones that can be reduced in their diet.
Okay.
So avoiding caffeinated drinks, aerated soft drinks, because they have a high solute content and stuff like that, encourages these women to or men to have reduction in their stone incidence. So stone prevention is very important in terms of encouraging the water drinking habit. When I say water, it's plain water and not any soft juices or aerated soft drinks, and giving them the appropriate stone diet depending upon what type of stone they have developed, correcting or optimizing the deficiencies in certain minerals in their body will go a long way in the prevention.
Okay. And doctor, you're suggesting it's a lifestyle disease.
Stone is definitely a lifestyle disease. Interestingly, stone is very common in South Asia, where we have extreme amount of heats, and therefore we get dehydrated. And it's very common in the West because of two reasons. One, obesity, and other is because it's a cold climate, people don't drink water. But eventually everything stems down from the fact that there is inadequate water in the system. So by just increasing the water intake to adequate levels, we just make things better for the patient, reduce stones. So in this forum, I want to give some simple tricks. What is the amount of adequate water? That's a question everybody asks me. Is it 2 liters, 3 liters, 5, 10? I give a simple answer. If you drink adequate water, when you pass urine, it should be like tap water. If your urine is yellow in color, it means your water intake is inadequate. You need to step it up. So you yourself is the best judge for your own water intake. But if an average adult, working adult, you need about at least 2 liters of water a day, and if you're a stone former, you need 3 liters of water a day on an average basis. Of course, there are special conditions such as renal failure where we have to modify and all, but generally this will be applicable. In order to just highlight what Dr. Meera said, I just generally give 4 instructions to all stone patients. Water 3 liters a day, milk at least 2 cups a day. It's a common myth to say milk intake will cause stones. So once a stone former comes, elderly people in the house will say stop milk, stop yogurt. And they used to say it's because of calcium. In fact, calcium is protective to stones. The gut calcium binds with oxalate and prevents oxalate absorption. It's the oxalate which is the problem rather than calcium.
Okay.
At the same token, high amount of calcium intake such as calcium supplements also can cause stones. So the best compromise is that an average adult consumes at least 2 cups of milk a day in any form.
Okay.
The third thing is what causes stones, such as oxalates. And where does the oxalate come from? It comes from chocolates.
Okay.
It comes from the soft drinks that we drink.
Okay.
And so avoiding these things will reduce the oxalate content in our gut and therefore the stone formation. And I also tell people to avoid juices, especially in stone formers, because if juice is the primary component of fluid intake for you, the amount of solute load you take is very high, which forms stones. So instead of taking a juice, have an apple, have a fruit. And the last thing, as Dr. Meera rightly said, is limiting the intake of so-called greens, the patta gopis and fulla gopis and spinaches will do a lot of favor. It does not mean you have to stop it, but reducing it to 1 to 2 times a week will do the job. And if you are a heavy meat intake person, that also forms stone, called uric acid stones. So once again, everything in limited is always good.
So, doctor, like in a way, you have said what you have mentioned. Taking too much of a chocolate leads you to the stone formation. So, our childrens are destined for that. I mean, as a lifestyle, since it's a lifestyle disease, so we must disrupt the cause to begin
Yes.
with.
Yes.
Okay, so now, sir, like we would like to have some lecture on UTI,
Urinary tract infection.
urinary tract
Dr.
infection.
Meera will be the best person to talk.
Please, ma'am.
As urinary tract infection is something where there is an overgrowth of the bacteria within the urinary tract, especially the lower urinary tract, but can ascend itself up to affect the tubes connecting the kidneys and the kidneys themselves. Now, this is common in men and women, more so in women compared to men.
Why?
Why? Because of the proximity of the female reproductive system to the urinary passage, and because the women's urethra or the outlet passage is only 2 centimeters long, and the various physiological and hormonal changes which the woman is subjected to during the process of life. Say, for example, onset of periods, the regular periods every month, and therefore the hormonal changes attendant to it, the sexual practices, the pregnancy and delivery related problems, the menopause related hormonal deficiencies, so on and so forth, are multiple staged risk factor episodes in the woman's reproductive life, thereby predisposing women to be at higher risk of contracting a urinary tract infection. So, the usual signs and symptoms, I'm sure Dr. Ragavan will enlighten us about what are the usual signs and symptoms of urinary tract infection.
The most common urinary tract infection is what we call cystitis that happens in the bladder. So we'll stick with that and talk about the rare things a bit later. But generally, bladder infection, usually patients will present with lots of pain, frequency of urination, passing small quantity of urine, and lots of burning sensation when they pass urine, with or without fever. So these are generally the symptoms occurring in the bladder infection. When the patient also has an infection ascending to the kidney and they have something called pyelonephritis, they can be quite morbidly sick as well. And some of those patients may require hospitalization and injectable antibiotics. So generally these are the symptoms. Rarely men do get infection involving the prostate and the testes, which is an infection coming out of the urinary tract.
Okay.
And they will have slightly different set of symptoms in addition to the existing one. They may have pain in the perineum, swelling of the scrotum, lot of tenderness in the scrotum, and they may have redness around the scrotum as well. So these are the symptoms generally of urinary tract. Keep in mind, most common is bladder infection.
Okay.
Women have similar symptoms, but they usually complain of frequency and urgency, frequent visits to washroom and urgency. This sometimes can be confused with overactive bladder, or all overactive bladder symptoms can be treated as urinary tract infection without proving it is an infection with injudicious use of antibiotics. That also is detrimental as far as community health is concerned, because if we dish out antibiotics with free will without having confirmed there is an infection, that is the reason why we have got superbugs now, which have become resistant to pretty much every single antibiotic on the planet. So that injudicious usage or self-medication of antibiotics with symptoms which you're not sure whether it's due to infection should be strongly discouraged. Self-medication is something which should be avoided. Prescribing your own medication to your kith and kin should be strongly discouraged, because your bug might not be the same one what the other person is harboring. These are public health issues whereby we can then prevent superbug resistance to various antibiotics. This is a message I would like to give out to the audience here, so that they understand and take that responsibility of visiting a doctor before they self-medicate themselves.
At this time, can we add a message to the health professionals as well, who are probably seeing this video, is to say that adequate treatment for adequate length and adequate dosing. This is very important. You cannot have a haphazard, half-hearted treatment in half of the dose. So each drug has an adequate dose, an adequate length, that much of, and the adequate drug has to be used as well. Nowadays we are finding a lot of resistance to commonly used drugs, but we also find the same drug is being used again and again. So that treatment effort itself is wasted when the same drug which is resistant is being used. So the healthcare professional should be aware of this situation.
So we must not only be knowledgeable, but we need to be wise in applying and strike the balance for the welfare of patient and doctor, and build up a doctor-patient good relationship.
Yeah.
Thank
The usual stipulated dose is about 5 to 7 days, and if somebody is not becoming better, the reason should be sought out for whether the bug is resistant to that particular antibiotic, are we giving the right medication, or is there something else why the woman is not or the man is not getting better with the treatment. It could be an obstruction in the form of a stone, or in diabetic patients it could be an obstruction in the kidney system, or we are probably dealing with an infection which is ascended up the kidneys and warranting an IV medication or even surgical intervention. So anything which doesn't get better with the 5 to 7 days of the stipulated dosage time has to be escalated and referred to a specialist and not dealt with in the community.
At the same time, can you just convey a simple UTI prevention or reducing UTI incidence
in general,
especially for women?
Very true that within the prevailing heat conditions, we get a lot more people coming in with urinary tract infection, and the cornerstone for that is adequate water intake. So, as we already mentioned, adequate water intake entails 2 to 3 liters. Make sure your urine is like tap water, clear and not malodorous or colored. So that will ensure that adequate hydration is taking place. Avoid excess caffeine or soft drinks in the diet, and also make sure when you exercise or sweat it out, you top up your hydration so that you don't develop a urinary tract infection. Ablution practices or perineal hygiene is very, very important, especially as girl children are concerned or elderly women are concerned. So teach children or ensure the elderly women wipe themselves front to back so they do not self-contaminate and predispose themselves to repetitive urinary tract infection. overt perineal hygiene is something which is to be strongly discouraged, because that denudes all the good bacteria, and women are then predisposed to overgrowth of abnormal bacteria and fungal, and thereby predisposed to urinary tract infection. So these are some of the general myths and practices which are prevalent in our society, which has to be emphasized so that women are not predisposed to urinary tract infection.
So these small changes can contribute
A long way to prevent
to very healthy lifestyle
Definitely.
and rewarding lifestyle as well. Thanks, doctors, for enlightening us on very important issues which are very much prevalent in our own demography, and helping them, showing them the path to lead a healthier lifestyle. Thank you again.
Thank you.
Thank you so much.